All right, let's dive into a topic that is absolutely guaranteed to show up on your exams. Gout. We're going to break down everything you need to know from the classic patient presentation all the way to the biggest treatment traps. Let's get right into it. Picture this. This is the classic story you are going to see over and over and over again. A patient wakes up in the middle of the night in just absolute agony. This isn't your everyday arthritis. No, this is the dramatic, unmistakable signature of an acute gout attack. So, what's really going on here under the hood? Let's break down the fundamental problem, and then we'll build that classic patient profile you have to be able to spot from a mile away.
Okay, if you only remember one single thing from this entire explainer, make it this. Gout is a disease of crystals. That's it. When you've got way too much uric acid floating around in the blood, that's hyperuricemia, these tiny, sharp little monosodium urate crystals can start to form. And when they deposit in your joints, your body's immune system freaks out and launches this massive inflammatory response.
So, who walks into your clinic with this? For your exams, you gotta recognize this patient instantly. I want you to think of a middle-aged man or maybe a postmenopausal woman. They often have other issues, like high blood pressure, and they're probably taking a diuretic. You add in a diet full of red meat and maybe some beer, and boom, you have the perfect storm for a gout attack. Let's move on to what this actually looks like. Recognizing that acute attack is absolutely critical, and you can bet that test raters love to ask about its specific features. And here it is, the #1 superstar sign you have to know, podagra. That's the fancy medical term for gout hammering the big toe, the first MTP joint. Over half of all first-time attacks happen right here. So when you see the word podagra, your brain should just scream gout. And this is where a classic exam trap pops up. The attack comes on super fast. It's incredibly painful, and the joint is warm, red, and swollen. You know what else looks like that? Cellulitis, a skin infection. The key difference: unlike an infection, a gout attack will usually just go away on its own in about a week or so, even if you do nothing. Now, while that clinical picture can be screamingly obvious, you still need definitive proof. So how do you lock in the diagnosis and be 100% sure? This is absolutely non-negotiable. To be certain, you have to stick a needle in that poor, inflamed joint and pull out some of the fluid. That procedure, arthrocentesis, is the undisputed gold standard. And this is what you're looking for. This phrase right here is pure exam gold. Say it with me. Needle-shaped, negatively birringing crystals. Here's an easy way to remember it. Needle starts with N, negative starts with N. Needle plus negative equals gout. It's that simple. Okay, time for a critical thinking question, one that trips up so many students. Is it possible for a patient to be in the middle of a full-blown, agonizing gout attack and still have a totally normal uric acid level in their blood? What do you think? The answer is a huge, resounding yes. It's kind of paradoxical, right? But during that massive inflammatory flare, the body can actually get tricked into dumping more uric acid through the kidneys, which temporarily lowers the level in the blood. The take-home point here is crucial. A normal serum uric acid level does not, I repeat, does not rule out an acute gout attack. All right, let's switch gears to treatment. This is where a lot of mistakes get made because you have to think about it in two completely separate phases. First, you have to put out the immediate fire of an acute attack. Then you have to prevent future fires with long-term therapy. And you can see the clear divide right here. For an acute attack, your one and only goal is to stop the inflammation right now. We use drugs like NSAIDs, colchicine, or steroids for that. But for chronic management, the goal is totally different. We're trying to lower the body's total amount of uric acid to stop future attacks from ever happening. The drugs are different, the goals are different, they do not overlap. This brings us to probably the single most important high-yield management question in all of gout. When is it an absolute 100% no-go to start a patient on a urate-lowering drug like allopurinol? The answer is during an acute attack. Full stop. Why? Because starting a drug like allopurinol causes a sudden shift in uric acid levels, which can actually shake loose more crystals and make the inflammatory flare even worse. It is literally like throwing gasoline on a fire. So, what's the safe way to do it? You just follow these simple steps. 1, you wait. You wait until that acute attack is completely, totally gone. 2, you start allopurinol, but you start low.
3, and this is key, you add on a low-dose anti-inflammatory for the first few months to prevent another flare-up. And 4, you slowly raise the dose over time to get that uric acid level below 6.
Okay, we have covered a ton of ground, so let's lock in the absolute must-know, cannot forget facts with a quick, rapid-fire review. These are the essentials. First up, podagra. It's gout of the big toe. See it on a test, you think gout. Simple as that.
Second, the diagnosis. How do you confirm it? You're looking for those magic words, needle-shaped, negatively birefringent crystals in the joint fluid.
Third, the biggest trap. A normal uric acid level does not rule out an acute attack. Don't let them fool you with that one. And fourth, the cardinal rule of management. You never, ever, ever start allopurinol in the middle of a flare. So to wrap this all up, I want you to remember the core concept. Gout isn't just about a number on a lab report. It's a painful, inflammatory disease that's caused by crystals. If you really understand these key points we went over, you're not just going to pass the questions on your exam, you're going to absolutely master them.